Good afternoon, everyone. Thanks for hanging around and sticking this out till 4 o'clock. I appreciate it. My name is Dan Fedor, and I'm the Director of Reimbursement for US Rehab. US Rehab is a division of the VGM Group, and the VGM Group is a member service organization that has members of the provider community of medical equipment. So VGM is the parent company, and that deals with all different types of DME, respiratory, basic DME. The division I'm in is US Rehab, which is focusing on wheelchairs and mobility options and accessories. So again, thank you for sticking around. We got about an hour to talk about documentation life preserver. Just want to give you just a real quick background. I worked for Medicare for 6 years. That's how I got into the industry out of college. And then I worked for Pride and Quantum as their Director of Education and Compliance Officer for 13 years. So that's where I learned about wheelchairs and what the accessories are, what they do, just a lot more in depth with wheelchairs. And now with US Rehab, putting that together to help our members navigate all the insurances that are out there. As you know, there's a lot of insurances, a lot of different policies, different coverage criteria. And that's my primary goal on a daily basis, is to work with our members first to make sure they're educated on the policies. So who qualifies, who doesn't, what documentation you have to have. Second, if they do receive denials for equipment that should be approved, how to resolve that, what happens, how to quickly resolve it, so that the patient receives the product and that the provider of the equipment receives reimbursement for it, for their services. So that's what I do pretty much on a daily basis, and education as well, like this. I was glad to be asked back to ISS this year. I'm glad we're in person. It's really nice, isn't it? Virtual is good and everything, but in person is really nice. So glad you all are here. So we're going to get right into this. We have a lot to talk about. This is actually a 2-hour class, so I condensed it down to an hour. So there's some accessories that'll be cut out at the end. We're not going to get to it. I still included them. They're still in the PowerPoint. So if you didn't receive that and you do need to see it, you'd like to have a copy of this, at the end I have an email. Just email me and I'll send it to you. Or it should be out on the app, I think, as a handout. If it's not, we'll make sure we get it to you if you're interested in the presentation. First, I do want to say a couple things that I have to go over. The learning objectives. We're going to talk about identifying key requirements that must be clearly documented in the wheelchair evaluation with consideration of health insurance. Recognize how health insurers think and speak their language with your documentation so that they see what you see. Connect the dots in the wheelchair evaluation to ensure that the patient receives the medically necessary products in a timely manner. How many of you have written addendums? Anybody know that slows everything down, as you know, and it's not good for you either. I know you don't want to do an addendum. So we're going to talk about that, how to avoid that. That's the purpose of this whole class, is to avoid addendums. I'd say eliminate. I don't know if we're going to eliminate them, but try to avoid them as much as possible. And then just talk about who can do what in this process. There's a lot of hands involved in rehab, especially your complex power wheelchairs and complex manual with they title it the LCMP, the Licensed Certified Medical Professional Wheelchair Evaluation, usually the PT and OT doing that. And the ATP assessment, the ATP is an employee of the supplier, determining the equipment based off the clinical findings. So we're going to talk about kind of the fine line between who should be doing each part of that, and if there's any overlap allowed. So I do have to also include this, conflict of interest. As I mentioned, I work for US Rehab, a member service organization. So there are providers of medical equipment that are our members that pay dues to be members of US Rehab. So I just want to disclose that. There are manufacturers of wheelchairs that are also a member of US Rehab that have dues as well to be a member of our organization. But in no way will that affect the presentation. So what's the goal? Let's talk about that. But before I do, the title of this class, I just want to tell you where I got that from. Where did that come from? Documentation Life Preserver. So this class used to be titled in the past, No More Addendums. That's what I titled it. And I put the line through no and said reduced addendums because we're never going to get no more addendums, but we wanted to reduce it. I titled the documentation Life Preserver because my wife is an occupational therapist and she's an ATP as well. I'm not a clinician. I have an economics degree, so no clinical background, just what I've told you about my history. But my wife is an OT. She used to do wheelchair evaluations. And so we would have conversations about this, about documentation. And a lot of the comments that she would say to me is, don't they know this? Like, do I really have to spell this all out? This is the patient's second chair or third chair. Do I really have to talk about a cane, a walker, and a manual chair? They're in a complex rehab power wheelchair. And many times before we started talking about this in much more detail, she would be rewriting evaluations with an addendum on nights and weekends, after hours, because during the day she had to see patients. Didn't have time to, barely have time to write it the first time. Definitely don't have time to go back and write it again. So that's where this came from. If we look at what the payers are thinking, these insurances, and kind of just understand how to lay this out, doing obviously a very thorough, proper wheelchair evaluation, but then keeping in mind that there are key points that have to be made, again, for appropriate patients, that medically qualify for the item. There's key points that have to be addressed for them to see what you see and approve the item per their policy. And so that's what we've talked about, and it, again, one of the comments she said to me was, they want documentation. I'll give them documentation, kind of like, they want it. I'm gonna load them up with documentation, these insurances. But that doesn't help either, because the people on the inside reviewing these claims also have productivity requirements, just like you all do, when you're doing an evaluation, or anybody in a position, you have productivity you have to provide. So the reviewers at insurance companies also have to get through claims quickly. So the more you dump on them, the less chance they're going to find what they need to find, and the likelihood of a denial goes up. But if you just, streamline it to the point, addressing what they want to know, it does help. It definitely helps the process and the approval rate. So let's look at this. We know what's the goal. The goal to documentation or to rehab is rehabilitate the patients so they do not require the item. Sorry, I'm in your way here, blocking you. That's the goal. The ultimate goal is that. But if that doesn't occur, we have to select the most appropriate mobility assistive equipment item for the patient. The third bullet, I bolded the first part. Provide documentation for third-party payers in order for the patient to receive the medically necessary equipment in a timely manner with the least amount of financial liability. The first part's bolded because whether we like it or not, this is important, as you all know. If this patient with this condition truly qualifies for the item, but it's not on paper the proper way for the insurer, they're not going to pay it. And the likelihood of the person being able to pay out of pocket without the insurance paying is highly unlikely in many cases, especially mobility, power mobility, with the cost of it. They don't have $17,000, $15,000, $20,000 if the insurance company isn't paying. So it's important that it's documented properly for an evaluation, but also, again, hitting those key points so the insurance sees what you see and understands the qualifications. And when I say insurance, I'm mainly going to be talking about policy today for Medicare, as they are the big payer. There are so many other payers, as you know, so many other insurances with the Medicare replacement plans, with Medicaids, with the MCOs, the managed care organizations for the states. We can't get into all of those, but many are identical or similar, or they try to follow Medicare in many cases. So I'm going to keep it at that level of the Medicare policy. So we want to be efficient, obviously, for your productivity, for timely delivery of medical necessity products, because this is really important. The item, the wheelchair, the item with the accessories can't be delivered unless it's 100% perfect. You can't go back after the fact and change it. Once the date of service occurs, it's done. It's closed. The documentation had to be there prior to or on the date of service. There's no changing it after the fact. So that's really important. And that's why sometimes you may see delays in delivery and wonder, why is this happening? Why is it taking 2-3 months to get this product? for this person that needs it yesterday. I mean, they need it immediately. This is why. It's not the supplier in many cases. Now, recently, because of COVID and some other things, we've had some supply chain delays, but even that, this is really the reason. Documentation, having it perfect before you can go forward to the degree that the insurer wants is the challenge. And that's what I'm going to try to address. That's what I want to talk about. And we don't want to hold the person financially liable. I mean, they're getting a wheelchair. Maybe this is their first. It's a new condition, a new injury, or maybe it is their second or third chair. But if they qualify, we don't want to put that burden of financial liability on them. If they have insurance and the insurance should pay, we want them to pay, and that's important. So obviously, efficiency is doing it right the first time, getting it down, understanding what they want, so you don't have to be inefficient and redo it. You know, you don't want to redo work. We all want the intended outcome, which is to be able to deliver the product timely and move on to the next patient to help them. That's what we want to do. Everybody wants that in this process. So this is what we want to avoid. This is a common scenario that I hear about regularly. Again, in my role helping the medical equipment suppliers with documentation and reviewing it for them. They obtain the documentation and something's missing for what's being prescribed. The provider contacts the physician or therapist, explains X item that you're requesting isn't justified per Medicare's policy for this person. And many times, at least from the physician, I know suppliers have told me this, what do you need? Please tell me and I'll write an addendum. Like, what do you want? Just tell me what's missing. Which you can obviously be explained, this is the coverage criteria for this item per the policy. What is in the notes or the documentation doesn't justify the need for the item. Now take it from there if we have to write an addendum to address that deficiency or that issue that wasn't addressed. But that's the red flag, because now we're in a position of an addendum. And even though they're accepted, and they don't say you cannot have an addendum from the physician or from the wheelchair evaluation. It's just, it is a red flag. The reason is they think if this were true, why wouldn't it be documented during the original encounter? Why is it being written 2 weeks later, 3 weeks later in an addendum? And that's not a fact, but that's the thought, is if this were true, why are they doing it? So higher scrutiny now comes out. Already skeptical about paying up front, throw an addendum on it, now they're even more skeptical about paying. Not to say it won't happen, but again, we just want to avoid this if we can. So we're going to talk about how we can do that for wheelchairs, for these evaluations. Does anyone know how long an addendum can be after the original encounter, before it pretty much loses all its value? Any idea? Yeah, 30. 30 days is about the timeline where if it's over 30 days, I've seen them accept some over 30 days. I've seen them not accept them over 30 days. But the 30-day threshold is kind of like a rule of thumb. It's not firm in print saying 30 days, but that's kind of the rule of thumb. And I've had a discussion with one of the Medicare medical directors about that. And the answer was pretty much what we would think is, if it's 45 days, 60 days later, how did you remember that? Like, how many patients did you see between that? And you documented this. Is it being given to you to put in the notes, or do you remember that? So there's just more scrutiny and more skepticism with a late addendum. So we want to avoid them at all possible. If for some reason you do have to do one, I've seen claims deny for power wheelchairs, patient clearly qualified, everything was there, but the addendum wasn't formatted according to CMS's record-keeping principles. So they denied it. And that was what was on the denial. It actually said that. They cited this right here. So we don't want that to happen. I mean, that's terrible. The person needs the product, the documentation's solid, medical necessity's there. Unfortunately, we had to do an addendum, but then it wasn't done properly according to the record-keeping principles, so the payer denied it. So, they want you to clearly identify it as an addendum or an amendment. Correction, delay of entries, what happened here, when it is, dated, of course. And then they still have to provide the original content from the encounter. You can't just provide the addendum, the whole package, the original encounter note, LMN, wheelchair eval, and the addendum, noted as an addendum and dated. And then what changed? What changed from the original to the addendum? What was the addition? What was the clarification? They want to know that and see that. And that's pretty much what this says. And this is for that's for paper records, basically the same. Is it readable? We all know it has to be legible. For electronic health records, basically the same thing. I had someone recently, one of our members I think they were in Minnesota, sent me a denial, and they sent me this documentation, the wheelchair evaluation, and it had an addendum. And the addendum was, first, it wasn't noted as an addendum. You couldn't tell where it was. And it wasn't dated. But it was after the close of the evaluation. I mean, you could see that. It was clearly after it closed, signed, dated, co-signed by the physician, dated, and then it was added in. They denied it because, again, it didn't meet CMS's record-keeping principles. So just make sure, if you do have to do one, we want to make sure it's accepted so it doesn't delay the delivery of the product.
Okay.
Yes?
So does that mean if I'm gonna do it, then back to the bottom of the original evaluation, or just can it state addendum to letter of medical necessity dated blah 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 blah? I can come back to it on the regular.
Yeah, you can do it either way. You could, if it's an LMN, so for physicians with a chart note, it would be in the chart note. It'd be in the progress note, actually. For a wheelchair evaluation with a PT or OT, the LCMP, you could add it on if you can, but note it as addendum in the date. So if the encounter was on 2/14, the addendum's on 4/12/13 today, just 4/13 addendum, and then what it was. Yeah, what you're adding in there. An addendum, it also has to be logical. Like, you could do that. An example, just a real simple, basic example is, let's say you do the wheelchair evaluation and you have the manual muscle test documented, which is part of the normal wheelchair evaluation. And it proves weakness of the lower and upper extremities. So that could rule out the least costly items, the cane, the walker, the manual chair, possibly up to a scooter. So you do that, but there's no narrative explaining or stating the reason this patient, or least costly alternative, cane, walker, manual chair, were tried and failed or considered and ruled out due to bilateral upper and lower extremity weakness. But you didn't write that. You just have the content, the objective measurements there, but there's no narrative to say that. The narrative can be written as an addendum, of course, referring back to the manual muscle test. So that's acceptable. The other way around wouldn't work, because obviously you'd have to see the patient again to do the manual muscle test if you didn't do it. But just something like that is acceptable. So just a couple things on this, and then we're going to get right into the content. First, who can do what? When complex rehab is being provided, whether it be power or manual, so an ultra lightweight manual wheelchair, a manual tilt and space, or any power wheelchair with an alternative drive, other than the standard joystick, tilt and or recline, it's considered complex rehab. Once we go there, there must be what they call an LCMP specialty eval, a licensed certified medical professional, PTOT, and an ATP, has to do an in-person assessment. Basically, the LCMP is responsible, for your note, can only use a scribe if the scribe is not the provider. Basically should be documenting your own evaluation. The provider of the equipment can be there at the evaluation. The ATP can be there. They can educate, they can talk with you about policy, but really shouldn't be touching your document at all, and shouldn't even be scribing it for you. So that line is pretty clear. The ATP would be employee offers to write the evaluation or scribe for them. You obviously would not want to accept that. In some cases, and I've seen this, and that's the only reason I have this here, just want to make sure it's clear, these two documents need to be 100% separate. The ATP assessment should be a separate document from the wheelchair evaluation with the licensed certified medical professional. Again, they could both be together at the evaluation, and sometimes that's best to both be there. Not requirement though. It is not required that the ATP be at the evaluation, but a lot do that. But just keep in mind the documents do need to be separated. We've questioned this because of the different conflicting information over the past several years out there, and different providers doing different things. Providers of medical equipment I'm talking about. Some have written evaluations for therapists throughout the country, and they've taken it and just cut and pasted it and used that as the evaluation. Some have scribed for them, while others, when they ask, is this valid? Is this compliant to be doing this? And I've been asked that many times. I tell all our members, no, you shouldn't do this. And they say to me, well, my competitor's doing it, and the therapist would rather work with them because they're helping them. Or basically making it easier on them to do this, to do their job with all these constraints of productivity and all this documentation that sometimes takes up more time than the actual evaluation, writing it. And so the AOTA wrote this back in 2019. It's on their website under wheelchair eval, basically saying you shouldn't do this. This is not compliant, it's not ethical, and I think they used the word possibly illegal. The APTA issued the same thing. This was June of 2020, I think. Yeah, so it was a little bit later, but basically saying the same thing. Don't do this. Don't accept that. Scribing, writing, anything like that. Education, yes, but that's not allowed, and it definitely could lead to things. What comes out of that, one of the things, besides it just not being compliant, is, remember I just mentioned that scenario, provider A will help write the evaluation or scribe, provider B won't, because they're told this is not compliant. And if the referral, the therapist performing the wheelchair evaluation says, well, I'd rather work with provider A because it helps me than provider B, that basically is what? But it's a kickback. This is an anti-kickback violation, which is huge. It's a serious offense for everybody involved, the person doing it, the person accepting it, all around the horn. So it's just, again, not a good thing. We want to separate those two again. So let's get into the substance now to make it easier. Okay, one of the most important things to keep, let me ask first, any questions on that? Yes?
So when we get on the spec sheet, then we have to go back in and it shows up as an intent. And it's not truly an intent that should be include all the minute specs. Is there a suggestion that you have to make that not a red flag, because our EMR automatically has that status of intended?
Okay. It would be best if it didn't, but if it has to do that, I guess, is there a way to know all the options and accessories before that happens? Working with the supplier of the equipment? Okay. Right, right.
The clinician might not know.
Right. Okay.
We recommend headrest, but we don't know the code.
Okay. Did you,
We face this as well, and we've had some. So the EMR just knows that stuff was changed on a certain day by a person, not exactly what, where, and when. But we've been finding, we just sort of bracket, and use the list data, from the second tell, that hasn't been enough. I don't know if it would be in every market, but sometimes it's most.
right.
You also say I would go generic and you know if you're going to sell you're going to do a headrest hardware, you can document need for headrest hardware. You don't have to say it's a 14-inch with my, you don't have to do that. That's not necessary. You know what I mean? That's the whole stuff. The event that documents the general needs that reviewers here.
And that's a great point. That's a great point. And that's a great point. I'm glad you mentioned that because it doesn't have to be product specific, just accessory specific of the need. So yeah, if it can be known before, I know sometimes when the ATPs are with the evaluation, they know that. Like they'll know if you're ordering and justifying for a tilt and recline, we know there's going to be a headrest. We'll ask the question, do you need swing away mounting hardware on that headrest for transfers? Those are the pieces right there. There's a tilt and recline headrest and E1028 for swing away mounting hardware. There really would be nothing else in there unless it's custom. If it's a KO108 hopefully that's rare, off the charts, but yeah. Did you have that?
Fedor will finalize the application link with it, something like that. I think that's-
Okay.
But it's all data.
Yeah, and like I said, they won't automatically deny an addendum. So just make sure it says addendum, the date, what was done. If it has to be that way, try to avoid it, but they won't deny it as long as it's noted correctly. Yes. What kind of template? So the question was, could a provider provide a template to the therapist? You could provide a form, a blank form, basically with the questions that need to be addressed. But I wouldn't, and I know others have different opinions, other consultants and reimbursement people in the industry. I wouldn't provide like a Word document filled out because I've seen that cut and pasted a lot into the document, just changing the name and maybe yeah. So I would stay away from that if you could. It's more of just addressing this patient's condition. And if the question set's detailed enough, then the answers will be there. Just whether they qualify or not that's the decision of whether the patient may not qualify. But policy can be provided, of course. You can always provide policy bullet points. If tilt and recline, if the patient has Medicare and tilt and recline is the item you're prescribing or being prescribed, here's the bullet points. This is it. They do or they don't qualify. Yeah. Yeah. Did someone else? Yeah. So the ATP role, going back to the roles again, is not really I mean, they can do that, but their role is not to justify medical necessity for the item because it's not accepted anyway. So if the ATP documents why you need tilt and recline, at least Medicare and those that follow those rules won't accept what they write to justify the item because they have a financial interest. They work for the supplier of the equipment company, and they may not even be a clinician. Some are, though. Some are. But the financial interest has a conflict. They can't do that. So, I mean, when I've talked and educated on this, I've always said that that's not their role. Their role shouldn't be evaluating for medical necessity. It should be looking at the physician's face-to-face and the LCMP evaluation, and then picking the right equipment based on the limitations. That's where that comes from. And then selecting the product, of course, the make and model and who manufacturer they're going to use. Right, and that's the merge between the two. That's actually that's why they're both involved. That's why Medicare put it in policy. We need this and we need this, because they realize, yes, the LCMP, the therapist, may not know, the E2311 is the electronic connection between the tilt and recline and the joystick. But the ATP should know that. Now, to justify it, you would have to justify it, not the ATP. Yeah. Correct. Correct. Yeah, correct. Right. Yeah. 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 Something that's yeah. So for complex rehab products, there's a specialty eval, and it says the LCMP doing the specialty evaluation has to have training and rehabilitation. So if the general practitioner doesn't have that, then technically they shouldn't be doing that. They shouldn't be. But and the reason is because they don't want to see the canned template answers. Yeah, they want to see someone that's trained in rehab to write it out, basically why this person can't perform a function. Well, first, they know they can't perform a functional weight shift. What's the reason? What's the limitation that's causing that? And the manual muscle test to back that up. So, yeah, I mean, I know there's a lot of those systems out there that do that. Yeah. Hmm. That shouldn't be happening. Yeah. I know, I know. Yeah, it is. Yeah. Uh, I know. I mean, show them the AOTA, APTA, that may not work. I I had someone, Vince, I'll just tell you, I had someone, one of our members up in Idaho. I provided him with these two letters because he said the same thing. He said, nobody will work with us because we're doing what you say. We're not writing the eval, but my competitor's writing it for them, like not even just helping, writing it. And I said, here, show him this letter. And he came back to me about 2 weeks later and he said, they don't care. They don't care. They need help. So yeah,
Take those actions.
sure. Right. Right. Yeah. No.
And but then there was a problem with the they came back down. Therapist said, right?
Yeah. So let's talk about some least costly alternatives. But it's a good topic. I mean, we have to talk about this because it's still going on, and we just need to make sure it doesn't as much as it can. Least costly alternatives are always considered. As those of you in here that are writing it, and then those of you in here that are reviewing a wheelchair evaluation, that's critical with any payer for any item. I know I worked 6 years at the Region A contractor for Medicare. That was my first, entrance into this industry, and it was just drilled into us, least costly alternative. If this item isn't justified, we used to down code. They don't do that anymore. They'll pay or deny, but they used to down code to a least costly alternative. So always keeping that in mind. Whatever is being requested or prescribed is it unsafe? Is it unreasonable? Why? The why is critical. Can't just say it is. Patient can't use manual wheelchair, period. That doesn't do it. You know that. What's the reason? Upper extremity weakness, as noted, manual muscle test 2/5. Okay, there's my sentence. Done. Manual wheelchair could be out. But if that isn't there, that wouldn't be good. It's also good to, we tried this item and it failed, or we considered it and ruled it out. We don't have to try and fail with the least costly alternative, but at least think about it, consider it and rule it out. Why was it considered and ruled out? It's really helpful to have that in there if that's possible. Talking about each item along the way, which we're going to go through. This is just who does what part of it. Of course, the treating practitioner doing this face-to-face examination, which is required for power mobility, diagnoses the item, symptoms affecting mobility generally, how's this affecting the patient, and then a routine physical exam is enough for a face-to-face exam. The substance, when there's a LCMP involved, the wheelchair eval, is ruling out the cane, the walker, the manual chair, and the scooter, or stopping along the way, wherever we stop. Maybe the patient can't use a manual chair. Maybe a walker's enough to resolve the mobility limitation, or maybe it's a power wheelchair. You know, we don't know until we go through that. And this here that I have on the screen now, you'll see step 1. Have you all seen this 9-step MAE algorithm? Anybody know what that is? You have, yeah. So this is the policy for mobility assistive equipment. This is basically it from end to end. And this is what they use when they review documentation. When they review this, this is what they're looking at. And they're going through yes, no, and then go on or stop. So it's really good to look at this as it's being done, or just have this noted and memorize it as it's being written, because it's really important. First, what's the limitation? You have to identify the limitation. What does this patient have? And is it preventing the patient, A, from the beneficiary, they say in here, but from performing any MRADLs, mobility activities of daily living, mobility related activities of daily living? That would be better chair confined, pretty much, A. B is, no, this person is not A, but they're going to be at risk for hurting themselves if they try to ambulate with a walker. And here's why. Or they're going to be at risk for hurting themselves, B, if they try to propel a manual chair to perform MRADLs in the home. And here's why. Maybe they're on oxygen and they desaturate to an unsafe level. You know, if there's exertion from propelling, or pain even. Pain's acceptable. Or they can't get from point A to point B in a reasonable time frame. That's acceptable as well. It's not A, it's not B, but this person just can't get from point A to point B in their home, toileting, in a reasonable time frame. So we need to move up to the next item, whatever the next item is. As you go through, so once that's identified initially, at least, the limitation and generally how it's affecting them, then we go through the algorithm. And the second step is, are there conditions that would prevent them from safely using this product? Of course, if there are conditions, we have to address them on 3. They have to be compensated for because they have to be safe. So if there are no conditions, 2, then we just skip on ahead. But if there are, we have to resolve them. Or if we don't resolve them, we stop. This patient needs the product, there's a limitation, but they're not going to be safe using it. There's a cognitive issue, vision, judgment, something, so stop. The next is, are they willing to use it? They have to be willing to use the product. So first, they need it. Second, they don't have cognitive issues or they don't have an issue to safely use it. And if they do, it can be compensated for. Then are they willing to use it? If they see in the notes patient, is unwilling to use scooter, and I've seen them actually say that, then they're going to deny that because they'll think you need it, you can safely use it, but you're saying right here you're not going to use it, so it's going to sit on your porch probably. So we're not going to pay for it. This is we're all the way up to step 5, and now is where they get into the first least costly alternative, which is you have a limitation, and now what's the least expensive way to try to resolve that is a cane or walker. It is. It's the lowest level mobility aid and the cheapest. So it has to either be tried and failed or considered and ruled out with a reason. And when they look for reasons, I've seen some written where it says patient can't use manual wheelchair, like I just said earlier, or patient can't use walker, and we're here at walker, due to, again, weakness. That's a common sentence. But then there's no manual muscle test to prove that. So the payer will deny that, and in the denial will say that. There's no objective manual muscle test to prove it. It could be due to range of motion. It could be due to pain in the hip from arthritis. It could be a number of things. It doesn't have to be weakness, but whatever it is, if there's an objective measurement, it has to be there. Once we get to step 6, now it's going to be used, now it's going to be a wheelchair or a scooter. So we know it's bigger. It's not just a cane and walker. So it has to fit in the home. Because at least with Medicare, this item, the patient must qualify for it and need it to perform MRADLs in their home. They could take it outside, but they must qualify for it in the home first. Now, some Medicaids, depending on where you are all over the country, they don't care. They'll pay for it outside. Medicare, they won't, just for outdoor use. So if you can get around with a manual chair in your home, but you need a scooter to go outside or a power chair, they're not paying for it. Medicare won't. So this is the home assessment where the supplier of the equipment will do that. They'll go out and do a home assessment to make sure that a manual chair, a scooter, or a power chair will fit in the environment. Because again, if it won't fit in the environment, the payer, Medicare, will think, why pay for it? It's not going to work. So this is how it goes through their thought process as they're reviewing these claims. And then I threw this in because I get this question a lot about DME, durable medical equipment, and nursing homes, skilled nursing facilities, or assisted living or custodial care, depending on what it falls into. Just right off the top, DME is not covered by Medicare Part B when the patient's in a skilled facility or nursing home. Doesn't matter who's paying for the stay. I get that question a lot. Well, their Medicare Part A is not paying, or it's beyond the 100 days. So will DME be covered? No, it won't. And the reason for that is it's not considered home. It's considered an institution, and DME is only covered in the home. That's it. There's no other way around that one with DME. Now, some other items are covered, but wheelchairs and DME that we're talking about is not. Assisted living, it is though, or custodial, because that's considered home. So it is covered there. But it's important that the facility, it's identified specifically what it is. And that's how they're officially designated. They can't be registered and officially designated as a skilled facility and just say the patient's not getting skilled care, because it's still place of service 31, which is SNF, skilled nursing facility. And DME will not go through and pay if that's properly documented. But one other point on this is, what are we talking about? Oh, dining room, yeah. If it's assisted living or custodial, they will pay for DME, and eating is one of the MRADLs. So if the person can't get there safely or in a reasonable time frame, remember A, B, and C from the very first step, and it's documented, then they will pay for whatever the next level up is to enable them to do that, safely perform eating one of their MRADLs safely or in a timely manner. But that has to be documented as well. So once we get to step 7, we're in manual chairs. And there's a lot of manual chairs within manual chairs. There's standard, there's lightweight, there's high strength lightweight, there's ultra lightweight, there's tilt. We got a lot in there. There's heavy duty. We're starting at the base. We're starting at a K1, which is your standard manual wheelchair. But they want to know, do they have the upper extremity function to perform MRADLs with this manual chair? And these are the things I mentioned earlier: strength, kind of endurance, range of motion, coordination, any type of objective quantitative measurement that you can provide to support the case is important. So K1 is your standard basic entry-level manual chair, the heavier, bigger type manual chair. K2 is a hemi chair. This is for someone with a short stature, that needs maybe foot propulsion, seat to floor height. That would be documented. They can move to that. The K3 is a lightweight, just lighter weight. So it is easier to propel than a standard because you don't have the body weight plus the weight of the chair. And as it says right here, remember the first slide when we got to medical necessity was least costly alternative? I mean, they put it, this is cut and pasted right out of the policy. Cannot self-propel in a standard in the home and can self-propel in a lightweight. So that has to be explained. Can't self-propel in a standard, can self-propel in a lightweight, and why. The why is always important. High strength lightweight, same thing. It's the next level up. And as we keep going, the cost keeps going up, the reimbursement rate. So think about that. As the reimbursement rate goes up, the scrutiny goes up. Of course, they're going to say, why? Why are we paying? Why is this being asked for? And so in this type of product is seat depth, width, and height that you can't get in anything below that. And it actually says it somewhere in here, right here. No, up there. Yeah. Where does it say it? Oh, okay. I knew it said it somewhere. Yeah, a K1, 2, 3 would need to be ruled out. And we move to a K5, and it says it again here, a K1, 2, 3, and 4. Why weren't they options? Because they're cheaper, they're less expensive. A K5 is your ultra lightweight manual wheelchair. They're going to ask the question, and now this definitely, this is considered complex rehab now. The first 4 were not. So now we're into, this has axle configuration of horizontal and vertical. It has wheel camber. It can be customized a lot more for the patient. So this is more of a custom type complex chair for a full-time user. This is a highly active full-time user that receives this type of product. And does anyone know why they would pay for this? This is the most expensive manual chair we're talking about. And why would they pay that for an ultra lightweight wheelchair for a full-time user, highly active person? For the proper positioning of the wheel, optimally configured. And why does it have to be right shoulder? If you think about it, if someone's a highly active full-time user and they're propelling a 1, 2, 3, or 4, how long are they going to do that before before they can't do it anymore and then need power, whether it be a scooter or a power chair? This now, yeah, because of the weight being ultra lightweight and the configuration, the thought from them and why they allow this is we're going to keep them in a manual chair. This person can propel, they want to propel, and this can be configured in a way that there's less shoulder injury, so they may be able to do this for a long period of time. Yes. No, they will. Mhm. Go ahead. Do you want to? Right. Long. Highly active full-time user. Yeah, exactly. And this is the one area I just mentioned about 5 minutes ago, in the home. They'll pay for it in the home. You can take it outside. This is actually the only one in our whole talk today that they do want to know what their outdoor activities are. The Medicare, I mean. They do want to know that. They want to know, is it for childcare? Is it work? Is it school? Is it what are they using this for? Because you think about a highly active user, you're not really highly active in your home. I mean, you could be, I guess, but they want to know that with this, and that supports the case. I've actually seen them deny when the in-home was only addressed for this, and they actually said in the denial, basically, what else is the patient doing with this chair? Like, what else is, why are we paying X thousands of dollars for this chair? Yeah. Yep. Okay. And the wheel, not only the camber, but the horizontal and vertical axle plate makes a big difference for where that wheel is when you're propelling. Your E1161, this is your manual tilt and space, and basically this is the coverage. That's all that's published. There's nothing else. But what they allow it for is when someone does require tilt, and they have a caregiver that's able to accommodate them, and they're not able to use a power wheelchair tilt, maybe due to a cognitive issue. Because otherwise they pay for power wheelchair with a tilt. Scooter. We can't skip the scooter. This was a discussion I had with my wife about this, where she said, why do I have to talk about a scooter? I mean, do I really need to? I'm like, yes, Laura, you need to just address the scooter. Otherwise, they're going to come back to you with a denial and say you need an addendum to address the scooter. It has to be. Now, it's easier with rehab when you're providing tilt, recline, items, complex rehab. Obviously, a scooter is not the choice. You can't do that. But it's not as easy, or it's not as black and white when it's from a scooter to a power chair with a captain seat, that van style seat, when there's no power positioning, there's no tilt, there's no recline on it. It's a little bit more fuzzier because, yes, the scooter you have to be able to transfer. You have a platform and a tiller, so it is harder to transfer on and off of a scooter compared to swing away or a flip up foot plate, where and a flip up armrest too, where you could transfer. So that has to be addressed. Operating a tiller, on a scooter's like this, so your range of motion, strength, dexterity in your hands compared to the joystick, easier, and functional, maybe not for some. Maintaining postural stability, on a scooter is not the same. And then it has to fit in the home, of course. So that's the final piece. Some scooters will, some scooters won't, based on the patient's home and the size of scooter they need based on their weight. So that alone could rule out a scooter for a power wheelchair if that's the case. It doesn't fit in their environment. But all those things have to be considered. At this point, we're up to a power wheelchair. So this is our final step. We flew through 9 steps, but this is what they do. So keep that in mind as you're going through, writing it or reading it, of this is what they're looking at. And if you can address all that, we're 90% there. Now, this is just for the base item. As you all know, if you provide complex rehab or document for that, there's a lot of accessories. There's a ton of accessories. So each accessory, each separate item does also have to be addressed. The medical necessity, why you're ordering that or prescribing that or documenting it. And if there is a least costly alternative, why that wasn't an option. And I'm going to give you an example of one of the major accessories where that comes into play in a minute. So at this point, it would be a power wheelchair with a captain seat, a van style seat. Okay. Yeah.
Can you address that here about caregiver dependability? How specific do we need to be about the inability of a caregiver? Like, is it sufficient to say they're 18
Oh, yeah.
and have that problem? Like, how specific? Because that one gets a little tricky on the.
It's tricky. This one's tricky right here. It is. It's in there because it is in policy. And what this kind of summarizing what this means right here, this note, is that if the patient doesn't have the cognitive ability or functional or not functional, they can't safely operate the product themselves, the power wheelchair. You're going to drop back to a manual wheelchair then for the caregiver to be able to accommodate them in the manual wheelchair. But let's say the caregiver can't do that. They have limitations. Then they can bounce back up to the power wheelchair with the caregiver operating that for them. Even though they can't safely operate it, if they have a caregiver that can, they will do that. But all those dots have to be connected and very clear as to why we're bouncing back up. And it's Medicare. Yeah. It's like it's a little tricky because it is. But you have to document all that. Now, you said the caregiver, they would need their own, documentation as to why they can't assist the patient in the manual wheelchair, because that is the least costly alternative. This is going to be more expensive if that's the case. And just one side note on this, I've had this question a lot. Will they pay for an attendant control if we're back in this position? We went here, down, up, we're back here. If the person can operate the chair sometimes they can, but sometimes they can't, throughout the day, maybe toward the end of the day or every other day, or depending on the situation, and you'd have to explain why, then they will pay for an attendant control in that case, because you're not going to, how's the attendant going to safely operate the chair alongside them? They're not. But if they can never operate it safely, the chair, then they won't pay for an attendant control, because the thought is you have the joystick, it'll be remounted to the back as the attendant control. since the patient cannot operate it themselves safely at all. So then they won't do it. But again, that's a little trickier too. It has to be documented very thoroughly. You can you can get an attendant if they can operate the chair safely sometimes. And it's documented why they can't for the whole time of the day. And then when they can't, there's a caregiver that will be accommodating them in the wheelchair. You've had that? Yeah, and it does. And that's not safe for operating the chair. Yeah. Yep. So cushions, we have about 3 minutes, so I'm going to fly through this because I want to talk about tilt and recline, but it's here. It's in the PowerPoint. If you have any questions, you'll have my contact info at the end. Please reach out. We had a lot of good discussion here, so I wanted to do that. Cushions and back, skin protection cushions are covered A or B, basically, and there's a whole list of valid ICD-10 codes for both that you have to have. The one note I want to make on B, the person doesn't have to have an ulcer or have a history of an ulcer to get a skin protection cushion if they have B, which is a condition that's valid. So let's say MS, because that's a valid diagnosis for B, G35. But the therapist has to indicate that they have the inability to carry out the functional weight shift or impaired sensation in contact with the seating surface, because not everybody with MS has B. So they don't automatically qualify. There has to be the narrative. And the same holds true for positioning. Positioning, they have to have significant postural asymmetries. A valid ICD-10 for this is MS. G35 again is valid for this. It's acceptable. But if you don't identify the significant postural asymmetries, they're not going to pay it, because not everybody with MS has significant postural asymmetries. Well, if they don't have a valid ICD-10, no matter what you write, they're not going to pay for it. That I'm just passing it on. I'm with you. But if the valid ICD-10 is first, that has to be there, then the significant postural asymmetries. If you document significant postural asymmetries, or you document absent or impaired sensation, and they don't have a valid ICD-10, they're not going to pay for it, because that's step one. Yeah, it's been updated. Yeah, it is. It is. Unfortunately, there's, yeah. I mean, they do have what's called individual consideration. They do have that. Clinical judgment, they say. So they could do that, but it's rare and it's risky from what I've seen. So custom fabricated, anybody deal with these? Basically, again, this is another level up now. Now we're up to custom fabricated. Anytime you put custom, it's going to be costly, right? So they're going to scrutinize it and say, why not prefabricated? Why not what we just talked about? So you have to address that. First, they qualify for prefabricated, but you're going to custom, and here's the reason why. That's critical. But they do pay for it. So here's our tilt and recline. We're going to wrap up on this, I think, because this is really important. And this is a good example of least costly alternatives. And this is also a good example of where the policy is very misleading when you read it. This is the policy that's printed. And the way it is written, I didn't include the whole narrative up at the top, but basically it has those codes: tilt, recline, or tilt and recline. Tilt, recline, or tilt and recline. And you see it has these 3 bullets only. And then it has or at the end of each one. So the thought process is, if they have any of these bullets, I can give them tilt, I can give them recline, or I can give them tilt and recline. And we're good to go, but we're not. And the reason is tilt is the least costly alternative to tilt and recline. And even though the, resonant position papers and all the, the findings out there show that tilt and recline is best for pressure relief, pressure management, they want to know for that specific person why they can't use tilt alone if you only have bullet 1. So if you document this person unable to perform a functional weight shift and susceptible for developing a high risk for developing a pressure ulcer, the first thought in their mind is we'll pay for a tilt. If you want tilt and recline for bullet 1, you have to explain how you know tilt won't work. How is that determined that tilt and recline is necessary? It can't just be, well, that's best practice. It has to be for that specific patient, and then they will allow it. But if they have bullet 1 and bullet 2 or bullet 1 and bullet 3, then you don't even need to get into all that, because tilt would be for pressure, intermittent catheterization and transfers would be your recline, justifying the combo, or managing increased tone and spasticity. So that's how this is laid out. And again, it always goes back to that least costly alternative, which is what we started with and what we're going to end with, as how they look at this.